topics related to management of labor, or when the patient is in labor, how do we manage labor? So we start with, first of all, induction of labor. What is induction of labor? Induction of labor is if a patient isn't in labor but we want to deliver her, like all that we've read in the last 2 3 days, mild preeclampsia, you want to induce her at 37 weeks, or say she is fetal growth restriction with absent diastolic flow, you want to induce her, or suppose say she is diabetes and you want to induce her, she's not in labor but for whatever reason, or she's reached 40 weeks or 41 weeks, she's not gone into labor yet. So whatever reason you want to induce her, with the aim that you want her to achieve a vaginal delivery. Okay. So with when you want to achieve a vaginal delivery, that is when you want to induce labor. Of course, there has to be an indication. Common indications are all the medical complications जो मैंने लिखा ना, when to deliver. If any of those you want to deliver by vaginal delivery, or suppose a patient has come with pre-labor rupture of membranes, or she's gone past dates, or any medical complication which is necessitating delivery. Okay. So all of these you would want to induce labor. Okay. Now coming to the first of all, we'll discuss the Bishop score, the modified Bishop score. Then we'll discuss the different methods of induction of labor. So what is a modified Bishop score? So whenever we are planning to induce labor, yes, also maternal request. ठीक है, maternal request, patient क्या चाहता है कि मेरी आज डिलीवरी हो, so you plan accordingly induction. Now, modified Bishop score क्या है? So, whenever you're planning induction of labor, you do a per vaginal examination. Okay. And you do a PV examination and you assess the favorability for induction. Okay. So, Bishop score is done to assess the favorability for induction of labor. What does this mean? This means that there is a scoring system based on these factors, and if the score is good, if the score is a favorable score, that is, if the score is 6 or more, that means I can tell the patient that your chance of having a vaginal delivery is as good if you had come in spontaneous labor. So it just helps us tell the patient कि तुम्हारे chances favorable है. अगर उसका Bishop score poor होगा, then you have to tell her, see, it may take time. Okay, it is not as good as natural pains, but it will take time. The process will take time. It's very important to remember that a poor Bishops, when the score is less than 6, that does not mean we can't induce. Many of you think this. I don't know why you think this, but it does not mean this. You can induce with the bishops of 0, you can induce with the bishops of 10. It doesn't matter. Your aim is to achieve a vaginal delivery, but it helps you explain to the patient that, see, if your bishops is poor, you may take longer to respond. If your bishops is good, then your chances of going into labor, I mean, your chances of having a delivery are as good if you went into spontaneous labor. Yes. So, what are the components of the Bishop score? So, you have 5 components: the dilatation, effacement, consistency, position, and station. Easy to remember. Bishops itself is a mnemonic. So, B stands for Bishop, I stands for effacement. I'm writing it with an I, so you remember. S is for station of the fetal head. H is for hard or soft, that means consistency. O is for os dilatation, that means is the cervix, how much is the os dilated. And P is position of the cervix. So let's discuss each of them. What does cervical dilatation mean? Just look at this picture, then I'll go back. So when a patient is not in labor, this is how the cervix looks like. It's long, it's around 4 centimeters long, and the os is closed. This is the internal os, this is the external os, the os is closed. This is neither effaced nor dilated. But when she starts going into labor, what happens is effacement. Can you see the length has shortened? The shortening of the length of the cervix is called as effacement. Where has the cervix gone? It's become short, but where has it gone? It has gone into the lower uterine segment. Okay, so the lower uterine segment has taken up the cervix. What is the lower uterine segment? The lower uterine segment is basically the isthmus, the junction between the body and the cervix. This lower uterine segment starts developing in the third trimester of pregnancy, and in labor, the cervix becomes part of this lower uterine segment. Okay, so here you can see it is fully effaced. That means there is no cervix. It's completely part of the lower uterine segment. And then the cervix you can see starts dilating. So effacement usually takes place first, and then the cervix starts dilating also. Both can take place together also. There's no fixed rule. But you should understand what is effacement. Effacement is nothing but shortening of the cervix. It becomes shorter and shorter from 4 centimeter, 2 centimeter, 1 centimeter, then fully effaced. Okay. Then what is dilatation? Dilatation, the os is open and then it starts, so the os is closed, sorry, in the beginning, and then it starts opening up. Dilatation we say in terms of centimeters of dilatation. Consistency means the cervix is firm in consistency to begin with. It becomes softer and softer as labor progresses. Position means when you do a PV, the cervix will be posterior in the beginning. But as labor progresses, it becomes mid position, then it becomes anterior. And the last is the station of the presenting part. It comes from -3, -2, -1, 0, +1, +2, +3. Now, all these components are put together in this table. This is the modified Bishop score table, okay, where you have values from 0, 1, 2, and 3. And if you look at position and consistency, they have 0, 1, and 2. 0, 1, and 2. इसमें 3 वाला नहीं है. इसलिए maximum score is 13, okay, and least score is 0. And a favorable score is 6. Now, NEET PG till now has asked only the components of the Bishop score. They have never asked us to calculate the score, but INI has asked once to calculate the score. So there is no easy way out. You have to remember this. So it's not something which you can learn in a day, or in if I teach you, you remember. You have to keep revising it. This is one of the things you have to take a printout and stick in front of you, so that every day you go through it. It's there in my labor room also. मुझे भी याद नहीं होता. You have to keep checking. I remember a lot of it, but I always recheck to see if I am not made a mistake. So it is a little difficult. It's a little confusing, but basically, if you look at the dilatation, it starts with a closed os. Then score of 1 is 1 to 2 centimeters, score of 2 is 3 to 4, and score of 3 is 5 to 6. Okay, you rarely get a patient who is already in active labor. है ना? 5 centimeters plus means active labor. Okay, length is I told you uneffaced means 4 centimeters. Then you have 3 to 4, 1 to 2, and less than 1. Less than 1 means fully effaced. It's very, very thin. Then position and consistency are easy. Posterior, mid position, anterior, and firm, medium, soft. And then station from -3, then -2, then -1 and 0 are together, and the plus ones are together. So something which you have to keep remembering to understand how to calculate the Bishop score. The Bishop score or modified Bishop score में क्या difference है? पहले हम effacement in terms of percentage बोलते थे. So the Bishop score was effacement in terms of percentage. Now we talk about effacement in terms of length of the cervix. So the Bishop score was in terms of percentage. Modified Bishop score is in terms of length. How do we get cervical length? Practically, if I do a PV बच्चे and I feel कि इतना length है, जितना मेरा finger है, उतना cervix है. This is an uneffaced cervix. This is a 4 centimeter length. Okay, so with practice you get to know 4 centimeter, then 3, then 2, and well effaced less than 1 centimeter will be very, very thin. Okay, so in fact a fully effaced cervix is papery thin. जितना पेपर का कंसिस्टेंसी होता है उतना थिन सर्विक्स हो जाता है. ठीक है, so this is how you look at these things. Similarly, dilatation also comes with practice, right? So that is about the Bishop score. Now there is a term called cervical ripening. You need to know that cervical ripening is part of induction of labor. It is actually a continuum. In patients who have a poor Bishop score, in patients with a poor Bishop score, the initial part, the initial part of induction of labor is called as cervical ripening. Okay, so if we induce a patient with a Bishop score of 0, तुरंत वो लेबर पेन स्टार्ट नहीं होंगे. Initial 12 to 24 hours will go in ripening the cervix, in improving the Bishop score. Okay, and then she will go into labor. So try to understand that they are part of the same thing. Cervical ripening is the initial part of induction of labor when the patient has a poor Bishop score. It's not something different. It is part of induction of labor. Okay. Another example to give you what I mean by this is if I have a primigravida whose Bishop score is 0 or 1 or 2 or less than 6, okay, or a multi, any patient whose Bishop score is less than 6, I always ask them, especially this is for patients who go past dates beyond 40 weeks. We don't wait. The guidelines say you can wait till 41 weeks, but we see in our scenario, we usually induce by 40 weeks. So I tell the patient, ki, do you have a date in mind? Do you want to consult the Pandit ji or whatever? Or do you have some specific date in mind? We can plan your delivery on that date. ठीक है? तो पेशेंट बोलता है कि मुझे डिलीवरी चाहिए on 30th October. That is tomorrow. So, and then I'll do an assessment in the OPD. I find her Bishop score is poor. So I will say, then you need to get admitted today. Let's get you admitted in the afternoon or the evening because you're going to take time. It will take at least a good 12 hours for you to go into labor. So that much time I have to keep in my mind and I have to counsel the patient. Patient तो ये सोचेगा ना कि तुरंत जैसे movies में होता they will deliver quickly. ऐसे नहीं होता. It takes time. As against a woman, say a multigravida usually have favorable bishops. So a patient who comes to me, bishops is 8 or 9 or 7. The bishops is very favorable. For her, I will send, she says कि मुझे 30th October को delivery कराना है. I will admit that patient early morning tomorrow because I know she will respond very quickly to induction. So that's how you have to explain to the patient that this is how the process will be. So that's why this concept of ripening and induction of labor is important. Yes, Ashish, ripening means cervix को अपने Bishop score improve कराना है. Bishops is poor. You have to make it ripe. You have to make it soft, effaced, and shorten the length. And that will take time. That initial part of improving the Bishop score is called cervical ripening. Immediately, contractions will not start. Immediately, what's going to happen? First, the cervix is going to become soft. Okay, so somebody's written a really long message and has taken time to write this, I guess, but मुझे समझ नहीं आ रहा. Sometimes it happens to see that this morning I had to go to doormat for my mother, and the moment she learned that I was a post intern, she gave advice that medical field has become too negative. All doctors don't treat doctors well. This is something everyone knows, but ever since she advised me not to postpone any other good things in life because of this, her opinion and the way she advised me has taken this disturbing me since morning. That doormat is from is quite old. Uh, okay, so Nidisa, please message me separately. Okay, so don't form an opinion or don't get affected by one person's, why is everybody laughing? By one person's or one doctor's opinion of the field. That dermatologist must have had a very bad today and she probably took out her frustration when she met you. But it's not the same for everybody. We all have our bad days and good days. It is there for every profession. Now that you have chosen to be in this profession, it is a good idea to remain positive, to remain optimistic, because life will have its ups and downs. I always tell my students and everybody that life is a game of snakes and ladders. Snakes and ladders खेला है ना. So you keep falling है ना. You keep, and invariably यही होता है ना, snake ही मिलता है. मुझे तो snake ही मिलता है जब मैं खेलती हूँ. You rarely get the ladder, but the ladder does come and you do reach 100 है ना. So just remember that this is life, not only for doctors, for any profession. It's the same. ठीक है. सो यू हैव टू बी पॉजिटिव, यू हैव टू बी ऑप्टिमिस्टिक. अगर अभी से ऐसे सोचोगे, वो भी किसी वन पर्सन के एडवाइस पे, देन don't let it affect you or ruin your whole day for that. Okay, there are many nice moments, there are beautiful moments, and honestly, there is no profession like being a doctor in terms of the satisfaction and the joy it brings you. Especially, I am very biased towards my field, especially, and as a obstetrician, um there is nothing better. Nothing can beat the joy that you get a family when you deliver a baby. No matter what you have to go through to get it, you have to go through sleepless nights, you have to stay awake, you have to go in the middle of the night for delivery. Okay, but in the end, na, it's all worth it. So, itna negative nahi hona. You guys are so young. You should not get so upset by one person's perspective of the field. Okay, come back. Yeah, trust the process. Correct. Okay, so come back now. Let's study. उसको ज्यादा मत सोचो, है ना, किसी ने कुछ बोला है. Never let it affect you so much that it spoils your day. Okay. Now coming to prostaglandins. Prostaglandins. So coming to sorry, methods of induction of labor. Um, in we start with medical methods. Medical methods, may we have three important drugs. One is prostaglandins. Okay, come back. Okay, so I think that break was needed. She had to get it off her chest, and I had to respond because it was such a long message. Okay, so prostaglandins and oxytocin. Come back, everybody, come back. Okay, prostaglandins, may we have two prostaglandins. We have PGE1 and PGE2. PGE1 is also called as misoprostol. ठीक है. Misoprostol is available as a tablet, okay, and it is used for induction of labor. But we will discuss in detail about everything related to misoprostol here only. ठीक है. PGE2 क्या है? PGE2 is another prostaglandin used for induction of labor. This is dinoproston. ठीक है, and this is also used for induction of labor. And then we have oxytocin. So let's discuss this drug in detail, ताकि इस drug के बारे में सब कुछ ही cover हो जाए, all its uses, everything completely. ठीक है. So PGE1 is misoprostol. It's available, as you can see, as a tablet. ठीक है. Now, what are the uses of misoprostol? So let's start with the first trimester. First trimester में where do we use misoprostol? We use it in medical MTP, है ना? We use misoprostol. Sorry, we use misoprostol along with which drug? Mifepristone. ठीक है. So mifepristone we give 200 milligram orally, followed by misoprostol 48 hours later. ठीक है. So 48 hours later, misoprostol we give 800 microgram either vaginally or orally. ठीक है. So this is the protocol for medical termination of pregnancy, and this is can be done by the government of India up till 9 weeks of pregnancy. Now, where else do we use in the first trimester misoprostol? We use it whenever we want to dilate the cervix. For example, you want to do a dilatation and evacuation for, say, a surgical MTP or a molar pregnancy evacuation. Okay, or you want to do you have a patient who's come with a missed abortion and you want to do a dilatation and evacuation, जो surgical procedure है. तो cervix को dilate कैसे करोगे? You can dilate the cervix pharmacologically by giving misoprostol, that is PGE1, 400 microgram 2 hours before the procedure. This will cause pharmacological dilatation. You can also dilate the cervix using Hagar's dilators, but we usually do both. We give misoprostol and then intra-op we dilate using Hagar's dilators. This is mechanical dilatation. ठीक है. So medical MTP, mifepristone 200 milligram orally, followed 48 hours later by misoprostol 800 microgram per vaginal or orally. You also use it for dilatation and evacuation. We use it for dilating the cervix prior to doing the evacuation. So we give misoprostol 400 microgram 2 hours before the procedure, or we can even dilate the cervix using Hagar's dilators. This is separate. ठीक है? Second trimester में कहाँ use करोगे? Second trimester may be again for medical termination of pregnancy. Again, we give mifepristone followed by misoprostol. Here, the doses are not important to remember. Okay, where else do we use misoprostol? In the third trimester, we use it here, induction of labor. Here, we use very less doses. We use doses of 25 microgram. Can you see this? 25 microgram ka tablet. And remember, misoprostol is a very strong uterotonic. How does it act? It's a uterotonic. Okay, that means it causes vigorous uterine contractions. ज़्यादा dose में दोगे तो ज़्यादा contract करेगा. तो induction of labor में we have to be very careful. We give very less doses because it can cause sudden vigorous uterine contractions. We don't want that. We want थोड़ा contraction so the patient goes into labor. ठीक है? Then in the postpartum period, where do we use misoprostol? We use it for active management of third stage of labor. That is prevention of atonic PPH. What is AMTSL? Active management of third stage of labor, where the drug of choice is oxytocin. But if you don't have oxytocin, or if you don't have anybody who knows how to give an injection, you can give oral misoprostol 400 to 600 microgram. Just give her oral tablet once she has delivered the baby. This will contract the uterus. It is also used in treatment of atonic postpartum hemorrhage. Here you can give 800 to 1000 microgram of the drug to contract the uterus. So these are the uses of misoprostol or PGE1. Medical MTP in the first trimester, medical MTP in the second trimester, prior to doing a dilatation and evacuation to dilate the cervix. Then induction of labor, where we use much lesser doses. The FDA, however, remember, it is not approved for this use by the FDA. ठीक है, वैसे हम यूज करते हैं, but approved नहीं है because it causes vigorous uterine contractions. It is known to even cause uterine rupture if you give it in high doses. Just a second. Okay. It is used for IOL. Ankit, we do use it, but approved नहीं है. तो बहुत ध्यान से use करना होता है because it's a very strong drug. And then in postpartum period, it is used for active management, that is prevention of PPH and treatment of atonic PPH. So these are the uses of prostaglandin E1. ठीक है? Next is prostaglandin E2, that is dinoproston. What is dinoproston? It is a very mild uterotonic. It's not a strong uterotonic. It's much milder than misoprostol, and the only use is in induction of labor, is the only use. ठीक है, तो ये है easy remember. This is easy to remember, and it is also here. So your books will say cervical ripening and induction of labor. So it's the same thing I told you. So it ripens the cervix and the patient goes into labor. So it is available in as either a vaginal tablet. It is also available as an oral tablet, but the more common way of common route of administration is it's available as a gel. So it's available for intracervical installation of the gel. So yeah, you've all heard of Serviprime. I'm sure in internship you would have seen this drug. So it's used for intracervical administration. It's available like a syringe. है ना? It's available like a syringe. And the end part goes inside the cervix. Patla sa tube hai, plastic tube, it goes inside the cervix where you push in the gel intracervically. So dinoproston gel 0.5 milligram. Nobody's going to ask you the dose. Just remember ki intracervical administration is the common route, but it's also available as a vaginal tablet and an oral tablet. Khushi will discuss in PPH. Don't worry about the doses. कुछ important होगा तो I will tell you myself. ठीक है? हाँ, इसको फ्रिज में रखना होता है. This is kept between 2 to 8 degrees Celsius. Okay, so this is dinoproston or PGE2. Now, next is important drug for induction of labor is oxytocin. Now, oxytocin is available as an ampule. It's given as an IV infusion. Now, oxytocin is also a very important drug. You should know the uses. What are the uses of oxytocin? It is used for induction of labor. It is used for augmentation. So, more than induction, it is used for augmentation of labor. That is increasing the uterine contractions. Patient is already in labor, आपने contractions बढ़ाने हैं. In both, it is used as an IV infusion. Okay, so you mix the drug. Okay, so there are different regimes. The dosing is not important for you all. There are different regimes by which you can give this drug. There's low dose regime, high dose regime. Just remember it's given as an IV infusion. Then the most important use of this drug is in active management of third stage of labor, where it is the drug of choice. It is given as 10 international units intramuscular or intravenous. It is the drug of choice for prevention of atonic postpartum hemorrhage. Okay. Then what else? Then you have it is used for treatment of atonic postpartum hemorrhage. It is also used when there's a retained placenta. It can be used in retained placenta. Okay, because it will cause uterine contractions and the placenta gets expelled. It is also used in breast engorgement because remember that oxytocin also acts on the myoepithelial cells of the breast. So, अगर breasts engorged होते, it causes milk let down by contracting the myoepithelial cells of the breast. Okay, so these are the uses of common uses of oxytocin. Okay, can I change? Dose is not important, shall we? Because there are different dosing regimes. It's not something which is important. Now, coming to surgical methods of induction of labor. So, surgical methods, one method is look what's being done here. The finger is put and the cervix is open enough to allow one finger to enter. So, this is called a sweeping or a stripping of membranes. So, the finger is put and this is before sweep, this is after sweep. हुआ क्या है? You just put the finger in the cervix and separate the amniotic membrane from the underlying decidua जितना आपका finger allow करता है. ठीक है? This is called a sweeping or stripping of membranes. This is commonly done in the OPD. It prevents the patient from going past dates. Many patients, if you do a sweeping, they will go into labor in a few days. But there is always a risk of membrane rupture. So this is the problem with this procedure. It can lead to membrane rupture, and if you don't do it under aseptic precautions, it can lead to chorioamnionitis. So whether to do it or not do it, there's a big controversy कि करना चाहिए नहीं करना चाहिए, but it definitely reduces the incidence of post-dated pregnancy. Also, you can do it only if the os is open, at least one finger open for you to be able to do it. Okay, otherwise you're not able to do it. Okay, so this is how does it act? How does it cause the patient to go into labor? So by doing the stripping of membranes, what happens? Prostaglandins are released. Endogenous prostaglandins are released, and that leads to uterine contractions. Okay, so that's the mechanism of action. Another surgical method, which is more commonly done, but this is again more common for augmentation of labor, is an artificial rupture of membranes. What is an artificial rupture of membranes? You can see that the cervix has to be at least 3 centimeters dilated, which is very unusual to see if the patient is not in labor. So ARM is a method used for induction only if the Bishop score is very, very, very good. है ना? Or and hence it's more commonly used for augmentation. So ARM, oxytocin are commonly methods for augmentation of labor. How do you do an ARM? You can either use this instrument. This is called an amnio hook. or you can use this instrument. This is called a Coker's or a Kocher's forceps. Okay, Coker's forceps and an amnio hook. You can see it has a tooth at the end. So it's sharp. Okay, so one of the biggest advantages of doing an ARM is you can see the color of the amniotic fluid. So if the patient is past dates or post term where you think meconium may be present, do an ARM. It's an indication for doing an early ARM. Just hold on, please. Okay, sorry. So, so color of amniotic fluid is the biggest advantage. You can see the color of amniotic fluid, but again, this procedure is going to introduce infection, so chorioamnionitis is a risk. Now coming to mechanical methods. Mechanical methods, remember I told you yesterday molar pregnancy may we use laminaria tents. This is how the laminaria tent looks like. It is made of seaweed, okay, and it is hygroscopic. That means if you insert it inside the cervix, it is going to absorb water from the surroundings and it is going to swell up. And if it swells up, it dilates the cervix, and this is a mechanical method of cervical dilatation. It's not bamboo, it is made of seaweed. Okay, so India mein these are not available. But Indians are not far behind. We are very jugaru. What do we use in place of this? We use a Foley's catheter. ठीक है, Foley's catheter को cervix में डालो और bulb को inflate कर दो with 15 to 30 ml of saline. ठीक है, and that will open up the cervix. Okay, so it also acts like it will push the membranes away also. So some amount of prostaglandins get released and the patient goes into labor. So what we usually do is we put the Foley's one night before. Okay, and by morning usually the patient goes into labor. It's a very good method of induction of labor. Okay, so you can put the Foley, just a plain Foley's, or you can even put saline here. The saline is going to push the membranes away. So this is what can be done, not a condom catheter. This is simply Foley's catheter for induction of labor. This is a very good method if the patient has a previous LSCS, a previous cesarean section, and you want to induce her. This is a good method. Remember, prostaglandins are absolutely contraindicated in a patient who has a previous cesarean section. Okay, in a previous LSCS. Why are they completely, absolutely contraindicated? Because I told you they're very strong uterotonics. They can cause scar rupture. You can't predict कि वो contractions कैसे होंगे. Oxytocin also has been recommended to be used with caution in a patient with a previous LSCS. Oxytocin, you can control the drip rate. You can stop the infusion if you feel the contractions are too much. You can adjust the rate and adjust the contractions, but still it is to be used with caution with previous LSCS. Okay, so the best method in a patient with previous LSCS is to use mechanical induction, that is a Foley's catheter. Not for MTP, Nandini. We're talking about induction of labor. We're not talking about MTP. Okay. Now coming to some questions. All are used for induction of labor except same in our hospital also we do the same, but that's separate. Induction of labor, we all are used except yes, PGF2 alpha कहाँ use होता है? PGF2 alpha has again only one and only one use, that is the treatment of atonic postpartum hemorrhage. Again, it's a very, very strong, potent uterotonic. It causes significant uterine contractions and hence it is used only for treatment of atonic PPH और कहीं पे इसका use नहीं है. Similarly, PGE2 का एक ही use है, induction of labor. So it's easy to remember. PGE1 is the one which has many, many, many uses. Okay. A 30-year-old G2 presents at 40 weeks, 5 days. She has a history of prolonged pregnancy in her first pregnancy also and was induced. On examination, her Bishop score is 4, which is not a method of induction of labor in this patient. Correct. A. ARM. Why ARM? Because I told you, for an ARM, the Bishops has to be favorable. The cervix should be at least 3 centimeters dilated. Favorable Bishops के बिना आप ARM कर ही नहीं पाओगे. Here the Bishops is only 4. It is very unlikely the cervix will be 3 centimeters when the Bishops is 4. Gel you can use, Synto you can use, Foley's you can put in, but you can't do an ARM in this patient. ठीक है? Which of the following will you not do induction of labor? You'll induce oligohydramnios? Yes. You'll induce preeclampsia? Yes. PROM? Yes. Why won't you induce placenta previa? Because here you're not going to achieve a vaginal delivery. She'll start bleeding, है ना? You have to do a cesarean section. तो जहाँ cesarean section आपको पता है करना है, there you will not induce labor. Which is a contraindication to induction of labor with prostaglandin E1? A patient with a previous cesarean. I told you it's absolutely contraindicated. Prostaglandins are absolutely contraindicated for induction of labor in a patient with a previous cesarean section. Okay. This is the INI question which came in 2022 November. A 23-year-old primey is planned for induction of labor at 37 weeks for mild preeclampsia. She is 1 centimeters dilated and uneffaced. Cervix is soft and mid position, presenting part is at -3. What is her Bishop score? So let's see the Bishop score. है ना? So we have first of all the dilatation. The dilatation is 1 centimeter. 1 centimeter gets a score of 1. Uneffaced gets a score of 0. है ना? Then soft gets a score of 2. Mid position gets a score of 1. And the presenting part is at -3 station gets a score of 0. Am I right or am I wrong? है ना? मैंने ठीक बोला है या गलत बोला है? It looks like 4 है ना? But फिर भी कंफर्म कर लेना. ठीक है? So just confirm it once. As again I said, थोड़ा सा difficult है. You need to go through this again and again. It's something which you also have to go through right before your exam, especially the INI exam. A 34-year-old woman with a previous LSCS for breech is keen on a vaginal birth. She is 40 weeks and has not yet gone into labor. Which would be the best method for induction for her? So she's previous LSCS, Foley's mechanical induction, laminaria tent or Foley's is the best method. Don't use prostaglandins. Preferably don't use oxytocin also. Okay. Now we come to management of labor. Management of labor is basically a patient is now in labor. You're in the labor room. You've all done your labor room postings in and you've all done your internship. Some of you have done your internship, so you know what needs to be, or you have some idea what is done in the labor room. So first of all, you need to identify whether the patient is in true labor or false labor. What is true labor? True labor pains are pains which are increasing in intensity, increasing in duration, okay, and increasing in frequency. Whereas false labor, they are random. ठीक है, कभी आ रहा है कभी नहीं आ रहा है. They don't increase in intensity, duration or frequency. You are just filling registers in the labor room, that's okay. जब रजिस्टर भी फिल करते हो ना, तो लिखते हो तो यू वुड बी अंडरस्टैंडिंग समथिंग, राइट? कि व्हाट वाज द डिलीवरी, व्हाट वाज द बेबी वेट, वाज इट अ वैक्यूम, वाज इट अ फोर्सेप्स, है ना? सो समथिंग विल बी लर्निंग. ऐसे मत सोचो कि कुछ नहीं सीखा, कुछ तो सीखा है. ठीक है, बी पॉजिटिव, लाइफ इज फुल ऑफ बीइंग पॉजिटिव. ठीक है. नाउ कमिंग टू what else happens in true labor. True labor pains also is associated with cervical changes. That means cervical dilatation and effacement will happen in true labor. अगर true labor नहीं, अगर false labor है, there is going to be no cervical changes. आज सब बहुत इमोशनल हो रहे हैं, आई डोंट नो व्हाई. ओके देन, नॉर्मल डिलीवरी सिजेरियन असिस्ट किया है, मजा आया था. गुड, आई एम वेरी ग्लैड, आई गेट वेरी हैप्पी व्हेन आई सी कि somebody saying कि ऑब्स एंड गायनी में मजा आया था, बिकॉज एवरीबडी फील्स इट सो टॉक्सिक. ओके, धनतेरस के वजह से सेंटी हो रहे हो. फेवरेट पोस्टिंग, ओ आई एम सो हैप्पी. We've done 4 deliveries, very good, I'm very happy. मैंने इंटर्नशिप में एक भी डिलीवरी नहीं की थी, मैंने सारी डिलीवरीज पीजी में जाके किए थे. ओके, coming back. So, true labor, false labor. What else happens in true labor? True labor, giving any medicine, any sedation, any enema, pain will not stop. So, pain does not stop. Pain will progress. Pain progresses. ठीक है. False labor में, by giving enema or sedation, the pain will stop. Okay. Also remember, true labor, you will have show. What is show? Show is bloody mucoid discharge. Okay, so it is blood stained, bloody mucoid discharge. Whereas false labor may, there is no such thing. There is no show associated. Okay, how much do I earn monthly? Cerebellum is asking me this question. How much do I earn monthly? Let me tell you. I won't tell you the exact amount, but I'll give you an idea. इतना नहीं कमाते हैं. As obstetricians, gynecologists, you don't earn so much. Um, uh, Possibly as a woman, I would say you earn lesser than men, and that is a fact. Uh, Not only in this field, generally also, because a woman takes a break in her career for a lot of things family related. So same reason, I also was in medical college for the longest time, and I feel that I could have been probably 10 years ahead in my career if I had not had my kids and I had not taken that wala break. Okay, but that is a separate issue. Even if I had not taken the break as an obstetrician gynecologist, in this place I practice in Faridabad, which is on the outskirts of Delhi. जैसे गुड़गांव है ना, वैसे फरीदाबाद है. फरीदाबाद में there are 400 gynecologists, I think even more, है ना? So it's a small town and there are 400 gynecologists. तो कितने deliveries होंगे आप ये, so you can imagine. Everybody is just having, it's a lot of struggle. So it's not there are too many gynecologists, and although work है, ऐसा नहीं कि काम नहीं है, but you're not earning as much as say a urologist would be, or say as a cardiologist would be, or a super specialist. But it's not that bad also. ठीक है, you can live a nice आराम से happy life. ठीक है, so it's not, so for me money is not important. That's another thing which I want to give gyan to you maybe some other time. Life is not all about money. If you have to choose 3 things, money, fame and happiness, okay, what would you choose? Money, fame or happiness? ठीक है, happiness. Happiness is most, you should be happy with what you're doing. If you're not happy with what you're doing, then there's a problem. ठीक है, if you're happy, the other 2 things follow. Fame will follow, money will follow. Okay, so don't look for money. Don't have that as your primary goal. Your primary goal should be happiness. If you find that happiness, everything else will follow. Okay, money will follow. Money does follow. Doctors will earn, but yes, they start earning later in life, and then there's no end. You keep earning throughout your life. Like my brother works for, he used to work for Facebook, Meta, then he got laid off जब Facebook में सारे layoffs हुए थे. Now he's working for TikTok. He's not in India, he's outside. So he is 1 year elder to me. And for him, he's reached his peak. Okay. So now it's difficult for him to get jobs. Okay. Because there in that scenario, if you're an engineer, if you're in IT, or if you're in digital marketing and all these things, he's in digital marketing, you have they look for younger people. So he will probably retire in the next 10 years. Okay, whereas for us, we have no retirement age. So don't worry about money. That's what I mean to say. Money will keep following. He started earning much, much more than me very, very early on. But we start late, but we continue to do so. So don't worry about that. Okay. कमिंग बैक, हम बहुत ब्रेक्स ले रहे हैं, बहुत बीच में ना धनतेरस के वजह से बहुत सेंटी हो रहा है, बट लेट्स नॉट गेट सेंटी एंड लेट्स गेट बैक टू पढ़ाई पढ़ाई पढ़ाई, बहुत बहुत सारा कवर करना है आज. ओके, कमिंग टू स्टेजेस ऑफ लेबर. स्टेजेस ऑफ लेबर, you have 4 stages of labor. Okay, so first, I'm not looking at the chat box now for some time. Okay, some people will be getting very irritated कि मैम क्या बोल रही है. First stage of labor, second stage of labor, third stage and fourth stage. First stage of labor क्या है? First stage of labor, I'm not looking at the chat box, so don't, just concentrate here. Try not to ask questions or distract. Let's finish this on time. First stage of labor is from the onset of true labor pains, ठीक है, till full dilatation of the cervix. And what is full dilatation of the cervix? It is 10 centimeters. That is, the BPT is 9.5 है ना, तो उतना cervix has to open up for the head to come out. Second stage is from full dilatation to delivery of the baby. Third stage is delivery of baby to delivery of placenta. And fourth stage is 1 hour of observation following delivery of the placenta. Okay, because this is the time when maximum complications, especially what are we worried about? We're worried about postpartum hemorrhage. So it has to be a intensive monitoring of the patient during this stage. Okay. Now, in first stage of labor, you can further subclassify first stage of labor into a latent phase and an active phase. Now, this definition of latent and active has changed over the years. Pehle we used to say active phase starts at 3 centimeters. Then it changed to 4 centimeters. And in 2018, the WHO has now changed this to 5 centimeters, which is what all of you should remember, that active labor starts at 5 centimeters of cervical dilatation. The Americans have gone one step ahead. वो बोलते हैं 6 centimeters, but हम इतने आगे नहीं पहुंचे. अभी हम WHO को ही follow कर रहे हैं. 5 centimeters is active labor. ठीक है? So this is what you should remember. Now, what happens in stage 1 of labor? You're having what I just explained to you: dilatation and effacement of the cervix and formation of the lower uterine segment. The cervix gets taken up into the lower uterine segment. So this is what is happening. This is a patient who is not in labor. So you have an upper segment. This is the upper segment, and this is the lower uterine segment. How do we know it's the lower uterine segment? In front of it lies the bladder, and then here you have a uneffaced cervix, a long cervix. As labor starts, so this is an early stage of labor, you can see the lower segment has become thinned out. It's thinning out, and cervix has started opening up. And this cervix now becomes part of the lower uterine segment. पहले सिर्फ ये lower uterine segment था, अब ये पूरा lower uterine segment बन गया. This is taking up of the cervix, and the cervix becoming part of the lower uterine segment. And you can see the upper segment becomes thicker and it contracts, and the lower segment thins out. Okay, so this is what is happening in the first stage of labor. This is the early second stage, till here is the first stage of labor. Okay. Now look at this curve. This is a Purana curve. This was described by somebody called Friedman in the 1970s. फ्रीडमैन ने बताया था सबसे पहले कि जो फर्स्ट स्टेज ऑफ लेबर है, इट कैन बी डिवाइडेड इनटू लेटेंट एंड एक्टिव स्टेज. एंड फ्रीडमैन ने बोला कि एक्टिव स्टेज स्टार्ट्स एट 3 सेंटीमीटर्स. ठीक है, अब वो चेंज हो गया. बट दिस ग्राफ समटाइम्स इज आस्क्ड इन द एग्जाम. आई हैव सीन क्वेश्चंस where this graph has been asked because it's very important from historical perspective. Okay, so the latent phase, remember, has no defined duration. It can take place even over days. Okay, so there is no upper limit कि इतने टाइम में latent phase का इतना से इतना limit है. So it can take place over an undefined period of time. But once the patient enters the active phase, and Friedman described this as 3 centimeters, the cervix will dilate at a fixed rate. Okay, so he plotted this S-shaped curved, where he said the initial part is called the acceleration, then it's called the phase of maximum slope. This is called the phase of maximum slope. And then towards the end, when the patient is 8-9 centimeters dilated, ekdam last mein, the dilatation slows down, and that is called as deceleration. So the question that has come, which I have seen, is they have asked to mark one of the slopes. I think kuch ye tha, it was labeled as A, B, C, D, and they are asked to mark one of them. What is D? So this is latent phase. Then you have acceleration. Initial jo after the latent phase, once the patient becomes 3 centimeters, the cervix, the dilatation starts happening faster. Then there is a maximum slope where it is the maximum dilatation, and then it slows down towards the end before the patient enters the second stage. So this is from historical perspective. Of course, things have changed now. Things became 4 centimeter, then they became 5 centimeters. So things have drastically changed now. Okay. Now, what is important to understand is if a patient comes or the question says that the patient is in prolonged labor. Okay. And what is the definition of prolonged labor? This has also changed with time. Initially, what was described is that the cervix should dilate at 1 centimeters per hour. This is the basis of the WHO modified partograph, which we will discuss in detail. But अब ये भी change हो गया. So we'll discuss the changes happening. But suppose a patient, if we follow this rule, 1 centimeters per hour, if a patient comes to me and my resident calls me and says, ma'am, patient आइए 5 centimeters dilated, it is 8 o'clock right now. When do I expect her to be 10 centimeters? After how many hours? By 1 o'clock in the morning. है ना? 5 hours के बाद she will be fully dilated if I follow the 1 centimeters per hour. So suppose my resident calls me at 1 o'clock and says कि ma'am ये अभी 6 centimeters है. So that's not normal. That means the cervical dilatation has slowed down. It is not normal. So if patient has gone into prolonged labor. So if the patient has gone into prolonged labor, what should I think of? I should think of 3 P's. What are the 3 P's? The first P is the passage. That means there's a problem in the pelvis. है ना? The second is there is a problem in the passenger. That means there's a problem in the fetus. Passage means maybe it is an android pelvis, maybe it's an anthropoid pelvis. ठीक है? Passenger means there's a problem in the fetus. Maybe it is an occipito-posterior position. Maybe it is a big baby. Maybe it is a deflexed head. So some problem in the passenger. Maybe it is a brow or face. Third is a problem in the powers. That means the uterine contractions are not sufficient to allow normal progress of labor. So I will ask her to check the 3 things. कि pelvis देखा है आपने? Pelvis ठीक है? Passenger, is it occipital? What is the position of the fetus? How are the uterine contractions? So I will see where the problem is and try to correct a problem if possible. Okay, you can't correct a problem in the pelvis. You can only detect a problem in the fetus, so you can anticipate complications, but you can correct a problem in the powers. If the contractions are not good, very good, Aditya, you will augment labor. How will you augment labor? Usually, what we do first is we do an artificial rupture of membranes. Okay. And if this doesn't augment the contractions, we give oxytocin. Now, what is the end point? How do we know that the patient is getting, or how will my resident tell me, ma'am, iske contractions to अच्छे नहीं हैं? That means what is the definition of a good uterine contraction? So, those of you who worked in the labor room, अगर resident ने बताया कि contraction check करो, कैसे check करोगे? You put your hand over the fundus of the uterus. ठीक है, सिट विद द पेशेंट फॉर 10 मिनट्स, 10 मिनट तक वो हाथ रखना है, और सेकंड्स वाली घड़ी पहन के, जब पेशेंट व्हेन द यूट्रस स्टार्ट्स हार्डनिंग, ठीक है, उस टाइम से यू चेक, एंड till the hardening passes off, that much time you have to see in your watch how many seconds did that contraction last for, and how many contractions were there in 10 minutes. Okay, so a good uterine contraction is 4 to 5 contractions lasting for 40 to 45 seconds in 10 minutes. This is the definition of a good uterine contraction. This is your aim by doing an ARM or by giving oxytocin. We aim to achieve this level of uterine contraction. Okay? So this is what you should remember, that by augmenting labor, yeah, when you're looking for powers, this is what constitutes a good uterine contraction. Okay? Now coming to stage 2 of labor, patient has become fully dilated. You take her to the second stage labor room, है ना? Prepare her for delivery. ठीक है, 40 to 45 seconds. 4 to 5 contractions lasting for 40 to 45 seconds in 10 minutes. We check the contraction for 10 minutes. सेकेंड स्टेज ऑफ लेबर क्या है? सेकेंड स्टेज ऑफ लेबर में दिस इज द टाइम जब आप डिलीवरी कंडक्ट कर रहे हो, है ना? यू ऑल डिलीवर्ड यू ऑल सीन अ डिलीवरी, एटलीस्ट किसी कोई ऐसा है जिसने नहीं देखा है डिलीवरी अभी तक, आज तक? ओके, अमन हैजंट सीन. देखा है ना? देखना जरूरी. आई एम नॉट आस्किंग इफ यू असिस्टेड. Not, I'm not asking who has done. I'm saying who has not done. So I have an idea किसने नहीं देखा, not seen. Okay, it's all right. ठीक है, जरूरी नहीं है कि everybody would have seen. So you liked giving an episiotomy. Dr. Strange, the patient, would not have liked getting an episiotomy. Okay, so that's why your name is Dr. Strange, I guess. And you like doing strange things. Okay, now coming back to the second stage of labor. So second stage of labor में क्या हो रहा है कि this is what happens. The patient is fully dilated, okay, and she is ready for delivery when the head is seen without separating the labia. This is called the phase of crowning. ठीक है, so second stage में the patient's head starts crowning, she starts bearing down, she starts pushing, so you know that she is ready for delivery. Okay, how is the head born? The head is born by extension. So what are we doing as an obstetrician? What am I doing when I'm delivering the head? I am doing a controlled extension of the head. I'm not allowing it to pop out suddenly. If it pops out suddenly, there could be tears. So a controlled extension of the head. Okay, this towel here is allowing the controlled extension of the head to come out. This is called the Ritgen's maneuver, which is allowing a controlled extension of the head to happen and not allowing it to pop out suddenly. Now, second stage of labor में बहुत कुछ है, ठीक है? We will discuss this in more detail when we come to the WHO recommendations कि क्या करना चाहिए, क्या नहीं करना चाहिए. But one important, like Dr. Strange said, is episiotomy. So episiotomy, there's a lot of controversy in this, but now the final thing is that you should not be giving episiotomy routinely. We have to use an episiotomy restrictively. सबको नहीं देना है, ठीक है? Because routine episiotomy is not going to prevent perineal tears. Okay, so avoid giving routine episiotomy. Give it only in certain indications. What are the indications? Is if it's a big baby, if you're encountering shoulder dystocia and you need space to perform the maneuvers. ठीक है, हमारे यहाँ भी सबको देते हैं. That's the sad part, Bhavesh. ठीक है. सो यूजली अब प्राइमी मल्टीज में देने की जरूरत नहीं होती. प्राइमी ग्रेविडास में ना देयर पेरिनियम्स आर वेरी रिजिड. So some episiotomy, my personal opinion is it definitely helps in a primary gravida, but multi may we usually avoid. You would not give routinely in a multi gravida. Okay. Third is if you are using an instrumental delivery like forceps or vacuum. Fourth is if you are conducting a face to pubis delivery, you would want to prefer to give an episiotomy. Okay, so these are some indications. And the last is if you are conducting a breech delivery, an assisted breech delivery. So what happens is the head tends to get stuck. So giving an episiotomy gets more space. So assisted breech delivery episiotomy definitely helps. Yeah, strange. It's good for suture practicing. ठीक है. Okay, now coming to timing. कब देना? If you're giving an episiotomy, when will you give the episiotomy? You'll give it at the stage of crowning. ठीक है. Okay, sorry. I found strange justification a bit strange. Okay, so coming to crowning. Sorry, I'm making jokes about this Doctor Strange, but it's you made the atmosphere a little light. Okay. Coming to when do you give the episiotomy? When you're seeing the head without separating the labia, you give the episiotomy. Okay. What are the types of episiotomy? So there are two main types of an episiotomy. You can either cut straight down, that this is called a median episiotomy, or you can give a mediolateral episiotomy. Okay. Now, which is better, which is worse? So what are the advantages and disadvantages of a median and a mediolateral episiotomy? Now, a median episiotomy, as you can see, is very symmetrical. Median, everything is better in terms of healing is better. So, better healing, less pain. Okay, it is more symmetrical. So, better suturing, less chance of wound dehiscence. Okay, less dyspareunia later on. Okay, so it's better in all these terms. But if this gets extended, if by chance जो आपका assistant है उसने अच्छे से support नहीं दिया और ये extend हो गया, तो what's going to happen? It's going to cause a third or a fourth degree perineal tear, okay, which is affecting the anal sphincter or the rectum. So it is a disastrous consequence, and then the patient requires to be sutured, and then a lot of things are to be taken care of. So this is the main worry with a median episiotomy. Whereas a mediolateral episiotomy, if it gets extended, तो यहाँ पे कोई major structure नहीं है, doesn't matter. So extension is not a worry here, but it has less healing. I mean, poorer healing, poor healing, more pain, more wound dehiscence rates, because it's an asymmetrical cut. Okay, more dyspareunia later on. So it's not a good in terms of healing and pain, but it doesn't cause damage to any major structure. Yeah, yeah, 1 second. इसी का remote ही बा. In the dining room? Yeah, you can. But ask somebody to help you put it, okay? Okay. So this is median and mediolateral episiotomy. कैसे देते हैं episiotomy? This question has come as an image-based question. This is the episiotomy scissors. Everybody can identify it. What are the layers cut from inside out? You have the mucosa, you have the muscle, and then you have the skin. ठीक है, mucosa. And when you suture in the same way. Those who like suturing the episiotomy, mucosa, then muscle, then skin. Which muscle is cut? You have three muscles cut: the superficial and deep transverse perineal muscle, then the bulbospongiosus, and part of the levator Ani. Okay, so I think Dr. Strange is going to be quiet for some time now. Okay, so superficial and deep transverse perineae, the bulbospongiosus and part of the levator ani are the muscles cut in an episiotomy. When you suture in the same way. You first suture the mucosa, then the muscle, then the skin. So you should remember the order of suturing and what is cut in an episiotomy. Okay? So this is how you suture it. This is the mucosa. First you suture the mucosa, then you suture the muscle, and finally you suture the skin. Okay? Now coming to third stage of labor. Now this is a very very important topic. If you ask me na exam se pehle ma'am, what tell me three topics to read? I will say hypertension पढ़ लो. Second I will say APH पढ़ लो. And third I will say PPH पढ़ लो. These three तो पढ़ना ही पढ़ना है before the exam. ठीक है? Now what is when we talk about PPH, we talk about both prevention and treatment. Prevention is basically active management of third stage of labor, what we call, just a second, another. Okay, sorry. Okay. So AMTSL is prevention of PPH. So this term AMTSL was introduced by the WHO in the early 2000s and it picked up very well throughout the world. So when the WHO introduced this terminology, it had three main steps. Okay? First was administration of a uterotonic, and the uterotonic of choice is oxytocin, right? 10 units, IM or IV. It also said कि controlled contraction should be done to deliver the placenta. Okay? And third, it said you have to massage the uterus on abdominal palpation. Okay? The government of India also brought this into its guidelines. ठीक है, गवर्नमेंट ऑफ इंडिया ने एक और चीज ऐड किया यहाँ पे. स्टेप नंबर 0 इज रूल आउट what? Rule out what? Rule out twin. Very good, Pushpender. Rule out presence of another baby. Okay, because there may be undiagnosed twin pregnancy. It can happen. I have seen two in my career till now. A unbooked patient comes and there was another baby inside. The patient had no idea. Okay, so this can happen. So always do an abdominal examination, do a PV check कि कोई और membrane तो नहीं है, कोई और amniotic sac तो नहीं है, and then only give oxytocin. Then do controlled contraction for delivering the placenta and then massage the uterus. Okay, this was the initial AMTSL described by the WHO. Then in 2012, the WHO came out with another document with a refocused approach. What was this refocused approach? Number one, they said uterotonic to dena hi hai, wohi oxytocin 10 units IM or IV is the drug of choice. ये तो देना ही देना है. They also said introduced a new concept. This was newly introduced, delayed cord clamping. Now, this is not to prevent atonic PPH, but this program called AMTSL picked up so well the world over that the WHO said, let us utilize, because सब कर ही रहे हैं ये, let's utilize this part, this AMTSL to prevent something else. Let's prevent fetal neonatal anemia using this program. Okay. So they introduced delayed cord clamping, where the WHO said delay the cord clamping by 30 to 60 seconds after delivery. So just remember the 60 seconds. Okay. at least by 1 minute. The cord, wait for 1 minute before clamping the cord. This is going to prevent neonatal anemia. And the WHO says the only contraindication to doing a delayed cord clamping is what? What is the only contraindication? And this came in the FMG exam of this year. Is yes, a baby which requires resuscitation, no RH, no HIV. Okay, the only thing is a baby which requires resuscitation. That means a hypoxic baby, a distressed baby, a baby which is not crying at birth. उसको 1 minute नहीं देना, उसको तुरंत clamp करके start neonatal resuscitation. Okay, so the only contraindication is a baby which requires resuscitation as per the WHO. So if you've gone, the WHO document is available on the net. Go through it if you have time. And this is the only contraindication that is mentioned. The third thing is the WHO says perform a controlled cord traction if required, and only in the presence of whom? Only in the presence of a skilled birth attendant, because it was being found that CCT से क्या हो रहा था? Uterine inversions were happening. Okay, so uterine inversions were happening, and hence the WHO said in its new document that तभी करो अगर आता है करना, ठीक है, और तभी करो अगर जरूरत है करना. If the placenta has come out by itself, you don't need to do a controlled cord traction. ठीक है, so controlled cord traction, I will tell you what it is अभी थोड़ी देर में, but it is basically to deliver the placenta. And they said, so they removed the word uterine massage, and they said ki postpartum vigilance. That means see if the uterus is contracted. If it is not contracted, then do a massage. And they said ki check the vital signs of the patient following delivery. So they just changed the word from uterine massage to postpartum vigilance. And the fifth component was, because oxytocin needs to be refrigerated, check whether the cold chain is being maintained or not. This is also a very important thing, because if the cold chain is not being maintained, it will affect the efficacy of the drug. So these were the 5 components of the refocused approach in 2012. But question अभी भी इस पे आता है. Last INI-CT November में इस पे question आया हुआ है, arrange in order. ठीक है, so you should know, because the government of India hasn't changed yet. It's still following these 4 basic wale things. ये वाला भी आता है, ठीक है. Delayed cord clamping is very commonly asked in the exam. ठीक है. Then what happened? Then 2018 में the WHO came out with another document which said what all uterotonics can you use in prevention of PPH. Oxytocin तो is the drug of choice, ये तो हमें पता है, ये तो है ही, ठीक है. It's the best drug. But the WHO said you can use some other drugs also depending on the situation. For example, it said you can use carbetocin. What is carbetocin? It is a heat stable analog. Okay, that means it is stable at room temperature of oxytocin. So it's basically a synthetic oxytocin which is stable at room temperature. So it doesn't require cold chain to be maintained. So if you are working in a setup where you feel cold chain पे doubt है, कहीं रूरल एरिया में आप हो, आपको पता है कि लाइट बहुत जा रही है, जनरेटर नहीं है, कोल्ड चेन पक्का, oxytocin hasn't been stored properly, prefer in such places to give carbetocin. This drug was recently introduced in India in 2022, and जैसे introduce हुआ उसके अगले महीने INI का exam था, and INI people asked this question. They asked the dose. The dose is 100 microgram intramuscular or intravenous. ठीक है? So, is the dose of carbetocin. Then you have misoprostol. Misoprostol we've discussed. For prevention, the dose is 400 to 600 microgram oral tablet. Misoprostol is preferred in those areas जहाँ पे you don't have any doctor, any nurse, any skilled birth attendant. Just you don't have anybody who knows how to give an injection. Okay, so there are many places in India and the world where you have such things. You have untrained dyes, or you have trained dyes also who don't know how to give an intramuscular injection. So you give misoprostol. The recommended dose is 400 to 600 microgram. That is, one tablet is 200 micrograms. So 2 or 3 tablets orally खिला दो patient को. ठीक है. Then the WHO said you can give methergin also. Methergin, remember, the WHO mentions the only two contraindications to methergin, which the WHO mentions, is hypertension and heart disease. ठीक है? And then it also says you can give a fixed, so some countries have this. We don't have this. Something called symptometrin, where you have oxytocin plus ergometrin ka combined dose. ठीक है? So this is what the WHO said, कि apart from oxytocin, you can give all this. Yes, Jigar, you can give misoprostol. So misoprostol is a drug which you can give orally and you can give it submucosally. So sublingual, बकल, रेक्टल, पर रेक्टल, पर वेजाइनल, ये सारे रूट्स में दे सकते हो, ठीक है. बट फॉर द WHO mentions it to be given orally, but yes, many times we give it per rectally also. PV we usually don't give in a patient who has just delivered because वो bleed करती है ना थोड़ा थोड़ा, तो that can get washed out, है ना. But you can give it by any of these routes. 800 to 1000 खुशी is for treatment of atonic PPH. अभी हम बात कर रहे हैं prevention of atonic PPH. AMTSL means prevention, prophylaxis. ठीक है. Now coming, no, carbetocin is not contraindicated in asthmatics. Okay, it's the same as oxytocin. The only thing is carbetocin, as of today, it has been approved only for prevention of PPH. जैसे हम oxytocin treatment of PPH में भी देते हैं, अभी carbetocin, lot of studies are being done, but it hasn't yet been approved for treatment of PPH. ठीक है. Yes, carboprost, Harsh, correct. You're talking about carboprost, yes. So PGF2 alpha जो है ना, the WHO hasn't approved it for prevention. It's for treatment. Carboprost is PGF2 alpha. It is contraindicated in asthmatics, not carbetocin. Don't get confused between the two. पहले क्या पूछा था? Carbetocin नहीं पूछा था ना? Carbetocin and carboprost are different. Don't get confused. ठीक है? Now coming to, somebody was asking what is controlled cord traction. This is controlled cord traction. So controlled cord traction is pulling on the umbilical cord, okay, with one hand while pushing the uterus upwards with the other hand. This is traction plus counter traction. Counter traction given to prevent uterine inversion. This is called the modified Brandt Andrews technique. When do you perform controlled contraction? When you see the signs of placental separation. So baby बाहर आ गया, स्टेज 2 ऑफ लेबर हो गया. थर्ड स्टेज ऑफ लेबर क्या है? डिलीवरी ऑफ बेबी टू डिलीवरी ऑफ प्लेसेंटा. सो एज सून एज द बेबी इज आउट, वी डोंट स्टार्ट immediately pulling on the cord. We have to wait for signs of separation of the placenta. Water Trenexa Pravad is used for treatment of PPH, not prophylaxis. Okay, we will come to PPH treatment also. What are the signs of placental separation? So once the baby is out, you clamp the cord, you collect the cord blood if she's RH negative patient, है ना? And then you wait. You of course do the active management of third stage of labor. You give oxytocin, okay? And then you wait. What do you wait for? You wait for signs of placental separation. Okay, what are the signs of placental separation? Number one, there will be a gush of blood. Because एक बार placenta separate हो जाए ना, that retroplacental जो थोड़ा बहुत blood होता है, that comes out. Then your cord is here, cord नीचे जाएगा because it is coming, the placenta is coming down in the vagina from the uterus, it's coming down, so the cord will appear to lengthen. Then the uterus is contracting now. In a thin patient, you will see nicely the uterus contracting. It will appear as a suprapubic bulge. And if you do a PV, you will find that the placenta is lying in the vagina. So sudden gush of blood, apparent lengthening of the cord, suprapubic bulge, and placenta felt in the vagina are signs of placental separation. Once you see these signs of placental separation, now you will do controlled cord traction. काफी बार तो placenta अपने आप ही निकल जाता. You don't have to do anything. But if the placenta, you've seen these signs and the placenta still hasn't come out, you pull on the cord, ऐसे rotatory movements करके you pull on the cord and you push the placenta, you push the uterus upwards. ठीक है. Bulge क्या है? Bulge is the uterus. ये दिख रहा है ना? ये suprapubic bulge बन गया because the uterus has contracted. So it appears as a suprapubic bulge. Now, coming to a very important thing, that is the WHO recommendations of intrapartum care. This came out in 2018. The WHO brought out a new partogram called the Labor Care Guide. Okay, it also, this whole document is available on the net for anyone who wants to read it. I have put a summary of the recommendation कि क्या क्या changes, a lot of changes were brought about, and lot of things which should be done, which we were doing, should not be done now. So we'll go through those. Okay. Now, what the WHO says is that throughout labor, what should you do? The first thing is RMC. What is the KMC? Na kangaroo mother care. RMC is respectful maternity care. This I feel is a very very possible question in the forthcoming exams, because so much emphasis has been given to this concept, respectful maternity care or RMC. Okay. This is also a component, a very important component of Lakshya. What is Lakshya? Lakshya is Labor Room Quality Improvement Initiative. PSM में पढ़ा होगा है ना? So it is sort of standardizing the labor rooms around the country. It is like a accreditation of labor rooms around the country. So a very important component of Lakshya and of WHO is respectful maternity care. Okay, yes, there is so much lack of RMC in government hospitals in India. It's actually very, very sad. But I don't know. What could the possible reason be? I guess it's just too much workload, too less manpower. Patients also, uh, I mean, it's very painful. Labor is a very painful thing. So it's just a combination of all the factors. But try now that, I mean, you've all seen this happening. It's not right. Patients should be respected, and at least hitting and all these things, of course, should be avoided. Okay. Number two is इफेक्टिव कम्युनिकेशन. सो इफेक्टिव कम्युनिकेशन का मतलब क्या? पेशेंट को समझाना है. अगर पेशेंट को आप ARM कर रहे हो, आप समझाओगे कि नाउ आई एम डूइंग एन ARM. Okay, I am going to take out the water surrounding the baby. This will improve your contractions. If you're starting oxytocin, if you're giving misoprostol, you have to tell the patient why you are doing what you are doing. Okay, so make it a habit wherever you go and practice. Even if you don't take up obs and gynae, या जो भी अभी फाइनल ईयर में है जिसकी पोस्टिंग होनी बाकी है, ट्राई टू एस्टैब्लिश दीज प्रैक्टिसेस नाउ ओनली, बिकॉज आई हैव सीन my own residents and a lot of junior doctors, um, uh, the way they communicate with patients, I don't know, I think it's I think I told you I'm very old, but I feel ना इतना generation gap आ गया है ना कि I feel we when we were going through this phase which you are going through now, it was much different. um I think we were more patient, and we I don't know, just it's a separate thing. Just it's just a lot of I feel students these days are very impatient, and junior doctors are very impatient. They want to rise up the ladder very quickly, but they don't understand there are a lot of things go into becoming a good doctor. And I take classes for residents also, and one of the most important things I explain to them is your attitude and your behavior and the way you talk to a patient. Okay, that is, see, everybody, a lot of people have knowledge, a lot of people have skills, surgical skills, but very few people know how to talk to a patient, and how to just general conversation and how to talk. I see my own junior consultant and my own residents, and I try to teach them wherever possible, but I see many of them are not receptive. They don't like it when I tell them ki it's not right to talk to the patient this way, so they're not very accepting of my advice, is my main grouse. But I think with time they will learn, है ना? So talking to a patient itself is an art. I feel communicating with a patient is an art. Those of you who've been to doctors when you have been sick, you would understand this. Or when you've gone with your parents or somebody to a lot depends on how the doctor talks to you, that itself treats half the problem, है ना? Okay, okay. So, okay, thank you, Pushpender. I hope this helps. I mean, just whenever you see a senior doctor, somebody who inspires you, uh, in your college or in your hospital, or if you're working, if you're still working or doing your internship, there must be some doctors who really inspire you. Try to imbibe those practices in your own communication with the patient. Okay, so let's continue. Third is companionship. Companionship is very important. Companionship, it has been found by many studies that 1:1 care. That means every laboring patient, yeah, we'll take our dinner break around 9 o'clock. 1:1 care. Every patient के साथ अगर आप एक पर्सन दे दो, चाहे वो पर्सन उसका हस्बैंड हो या मदर इन लॉ, मत बिठाना उसके साथ, बाकी कोई भी ठीक है ना? एनी पर्सन विद हर, इवन अ पर्सन शी डजंट नो, अ हेल्थ केयर वर्कर, एनीवन, जस्ट मेक अ पर्सन सिट विद हर and just be with her. That itself will improve the outcome. It reduces the incidence of prolonged labor. Many studies have found that 1:1 care. Okay, it doesn't have to be a healthcare worker or some a doctor. It can be anybody under the sun. ठीक है, except the SARS. ठीक है. Then continuity of care. Continuity of care का क्या मतलब है कि, so I like teaching this topic because it makes you understand कि हम क्या करते थे लेबर रूम में और क्या करना चाहिए. Continuity of care means that नॉर्मली क्या होता है, दोज ऑफ यू वर्क इन लेबर रूम, ड्यूटी खत्म हो गई, भाग गए, है ना? और यू जस्ट द रेजिडेंट, इवन यू सीन द रेजिडेंट गिव ओवर, द रेजिडेंट विल स्टैंड इन द सेंटेंस कि ये पेशेंट का ये करना है, इस पेशेंट का ये करना है, इस पेशेंट का वो करना है, एंड दे विल राइट द ओवर इन द रजिस्टर एंड गो, है ना? But continuity of care means that you have to, if your duty time is over and I am handing over the duty to the next person, if I'm a nurse, if I'm a doctor, whoever I am handing over to the next person, I have to go to the bedside of the patient and say, ki she or he is so and so doctor, है ना? I am going, this person will now look after your care. So you have to tell the patient and tell them ki now this person will look after you, don't worry, everything is fine. So that is ensuring, and of course giving a proper handover to that patient, to the person, ki this needs to be done. ठीक है? So, thank you, Abhimanyu. But you will see many gynecologists like me. The sad part is most are not like me. Okay, now coming to the WHO, what the WHO says about the first stage of labor. First stage of labor now is 5 centimeters. So don't admit the patient till she is 5 centimeters dilated. ठीक है? इंडिया में ये पॉसिबल नहीं है. इंडिया में तो we usually, just a second. So India means not possible, but here it basically means don't admit to the labor room. You can admit to the ward, but bring her to the labor room only after 5 centimeters of cervical dilatation. Okay. As I said before, routine clinical pelvimetry is not recommended. The fetus is the best judge of the pelvis. ठीक है. रूटीन सीटीजी इज नॉट रिकमेंडेड एट एडमिशन. व्हाट इज सीटीजी? कार्डियोटोकोग्राम. मतलब it has been found that lot of unnecessary cesarean sections were being done. So routine CTG या NST. NST is done when the patient is antepartum. CTG is done when the patient is in labor. तो रूटीन सीटीजी भी नहीं करना. रूटीन पेरिनियल शेविंग नहीं करना है. रूटीन एनिमा नहीं देना है. सो बेसिकली लेबर इज अ नेचुरल प्रोसेस. So let things be as natural as possible. Do a PV every 4 hourly. Okay. Now, one thing which the WHO insists upon is to offer the every woman analgesia. Pain relief should be given in some form or the other. Okay. Either epidural if you have the facility, or opioids, or relaxation, or back massages. Something should be given in terms of pain relief. Okay. What else? Encourage her to move about. Allow her to take fluids, allow her to take oral intake of fluids and food. Do not keep her NBM. I've seen many places they keep the woman NBM. No, you have to allow her to take fluids and food. CTG is cardio tocography. ठीक है. Shaving से infection नहीं, shaving should not be done. Shaving is will increase the incidence of infection. And then routine amniotomy. What is amniotomy? It is ARM. रूटीन ऑक्सीटोसिन, एंटीस्पास्मोडिक्स आपने देखा होगा, एपिडोसिन, बस्कोपैन, ड्रोटावेरिन, दीज ऑल आर routinely given in labor rooms throughout India. है ना? क्यों देते हैं? कि जल्दी से डिलीवरी हो जाएगी, है ना? दे कॉज सर्वाइकल डायलिटेशन. बट रूटीन अनलेस इंडिकेटेड, डोंट गिव रूटीन IV fluids. So we have this habit कि जल्दी डिलीवर करो, है ना? I want to go home, I have a class at 5:30, I want my patient to deliver quickly. नहीं करना है. ठीक है. रूटीन, ARM, oxytocin, all these things only if indicated you do, otherwise don't do. ठीक है. Then, sorry, zoom out for a minute. ये लो, zoom out कर दिया. डॉक्टर स्ट्रेंज का कमेंट मिस कर दिया मैंने. क्या बोला डॉक्टर स्ट्रेंज ने? ओके. Next is second stage. Second stage, what should you do? Second stage should be, what is the choice for birth position? The woman, it's not a dorsal position, it is not a lithotomy position. The patient should choose. It's the patient's choice. She wants to stand and give birth, let her stand and give birth. She wants to squat and give birth, let her squat and give birth. She wants to lie on the lateral side, she wants to deliver in water. It's her choice. Okay? So this is a bit extreme, but the WHO says ki encourage in the patient, whatever choice the patient wants, encourage that. Okay? Follow the urge to push. So once she is fully dilated, many times we tell her start pushing. Unless she has that urge, unless the head presses against the rectum, वो urge आएगा नहीं. So let the descent happen. Let the urge come naturally. ठीक है? Now this has come as a question. This has come as a question. Techniques for preventing perineal trauma. How can you prevent perineal trauma? ठीक है. डोरेमोन, लिथोटमी या डोर्सल यूजली यही देते हैं हम इंडिया में, बट यू शुड अलाउ द पेशेंट हाउ शी वांट्स. प्रिवेंटिंग पेरिनियल ट्रॉमा कैसे करोगे? नंबर 1, by giving perineal support. That means the assistant will hold a towel against the perineum, okay, and when the baby is coming out, so that there is no tear. What else? A warm towel or a warm compress should be kept on the perineum. This will soften the tissue and prevent tears. And the third is perineal massage. That means with your fingers between the posterior fourchette and the skin, you massage the perineum. This will also soften the tissue. So perineal massage. These are the 3 ways to reduce the incidence of perineal trauma. Remember, episiotomy nahi dena hai. Episiotomy is not going to reduce the incidence of perineal trauma. Episiotomy itself is trauma, hai na? So giving episiotomy is not recommended routinely. एंड फंडल प्रेशर नहीं देना है. ठीक है. तो बेसिकली जो भी आप करते आए हो लेबर रूम में, ये सब गलत है. ठीक है. सो यू हैव टू रीलर्न व्हाट टू डू इन द लेबर रूम. इवन आई एम रीलर्निंग अ लॉट ऑफ थिंग्स, बट फंडल प्रेशर इज वन थिंग विच आई रियली हेट. आई हेट फंडल. इफ एनीबडी इन माई लेबर रूम गिव्स, दे ऑल नो नाउ कि फंडल नहीं देना मैम के लेबर रूम में. ठीक है. तो फंडल प्रेशर ऊपर चढ़ के जो देते हैं, इट्स वेरी ट्रॉमेटिक फॉर बोथ द पेशेंट, and I have seen bad complications happening. I've seen splenic rupture happening. It should not be given. Okay, so fundal pressure should not be given. Routine episiotomy should not be given. What is written here? Perineal support, warm compress, warm towel रखना है. Perineal massage. ठीक है, these will prevent perineal trauma. वो आप resident must have said ना, fundal pressure दो, नहीं देना चाहिए. It's not a nice thing. ठीक है. Okay. IV fluids routine nahi dena hai, shall be only if the patient is dehydrated. So here na routine nahi dena hai. If indicated, do an ARM. If indicated, give oxytocin. If indicated, give antispasmodics if indicate IV fluids. But many times you would have seen routinely we do all these things. She's 5 centimeter, do an ARM, start oxytocin. You want to deliver ki duty time, जब तक in your duty you want to quickly finish everything. नहीं तो जो अगला वाला आ रहा है वो गुस्सा करेगा कि इसकी डिलीवरी क्यों नहीं की अभी तक, है ना? Yes, Veram, I mean, at least in my practice, I try to follow all these private practice में और भी चक्कर होते हैं. You can't wait indefinitely. Patients attendants will come every hour and ask, अब क्या हुआ, अब क्या हुआ, अब क्या हुआ. So in India, na, it's very difficult to follow practice. As far as follow, we do try, especially if the patient is educated and understands, things become much easier. Okay. Next, third stage में we've covered this. So basically AMTSL, I won't go through it again. Active management of third stage of labor. Break at 9 o'clock बच्चे, है ना? Because मेस नहीं खुला होता है 9 o'clock से पहले कुछ बच्चों का, है ना? तो फिर कोई फायदा नहीं है. Fourth stage of labor is your vigilance. You're keeping a check. You're checking the uterine tone. Routine antibiotics are not recommended. Routine postpartum maternal assessment is recommended, and discharge after a vaginal delivery after 24 hours. Oh, mess closes at 9. I thought you said mess opens at 9. Michelle, yeah, I love my job. I cannot tell you how much I love my job. What I don't like, however, is having two jobs because I get very, very little time for myself. So that's what I have decided when I am 45 years old, I will quit practice. That is what I have decided. So abhi hai, although I'm old, but I have some years more of practice left. Okay. So डिनर ब्रेक कर लेते हैं बिकॉज कुछ बच्चों का मेस बंद हो जाएगा. लेट्स मीट बैक एट 9:05. ठीक है? एंड देन वी हैव टू कवर अ लॉट ऑफ टॉपिक्स, सो आई विल लेट यू गो टुडे ओनली आफ्टर वी फिनिश टुडेज क्लास. ओके, आई लुक mid-20s, जिगर. थैंक यू सो मच. आई डोंट थिंक आई लुक mid-20s दो. डॉक्टर स्ट्रेंज, वही ना, योर नेम इज वेरी फेमिलियर. तुम मेरे ग्रुप पे भी हो और तुम ही हो जो डालते हो दूसरे व्हाट्सएप वाले ग्रुप के मैसेजेस, है ना, लिंक्स. ठीक है, ओके ओके. 9:05, because this is again a very intensive topic partogram, because lot of changes in this also. I will try, Hassan, to finish by 11:30. Okay, I'll try my very best. Okay, previous slide ये लो. Not 9:15 बच्चे, 9:05 पे आ जाना. ठीक है?